What Clinical Coding Is presentation. My name's Sam Levy. I'm the Clinical Coding Improvement Manager at Manchester Foundation Trust. If you've got any questions as I'm going through the presentation, feel free to either just shout out or drop the questions into the chat, and Becky will stop me and I'll do my best to give you some answers. So let's get stuck in. So what is clinical coding is sort of the first thing that we need to cover. It's something I get asked quite a lot, and I had a really interesting conversation quite recently with a clinician who'd also just done a presentation where they touched upon clinical coding, and the first question they got was, that's great, but what do you mean when you talk about clinical coding? And the point he was making was that the clinicians know what it is, they know it exists, they know it's important, but actually they don't understand it. He described it as being like the dark arts, and it made me think that actually it's really true, because before I started coding, when I was applying just to get into the job, it's very inaccessible. There's no information out there on actually what is coding. It's quite hard to pick it up on Google just to even find it out. And then even once you get into the industry, it doesn't get much better. So here's the definition of clinical coding. It's a translation of medical terminology as written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking medical attention into a coded format. It's a very much a textbook definition. It's very stale, and largely it doesn't mean a lot to anyone. It certainly didn't mean a lot to me when I started coding. So in a lot of ways, the industry doesn't help itself in actually getting people to understand what it's about, even though it is really important. So we're kind of left like, okay, so what is clinical coding? So in its most simple terms, without making even my mum's eyes glaze over, it's the process that when a patient gets discharged from hospital, their admission sits on the trust PAS system, and that needs to be coded. So the patient's records, whether it's a physical case note or digital documentation, that's all reviewed by the clinical coder. And the coders then extract all of the relevant diagnostic and the procedural information, they analyse it, and they select the appropriate codes using the ICD-10 and the OPCS-4 classifications. What that means is they read through all that documentation that's been written by the clinical teams for that specific admission for the patient, and they translate all that medical terminology, and they use the two classifications to get the appropriate codes. Then they check all that against national coding standards and any local policies, and that verifies the code. So that's the actual process of coding. That's what clinical coding is. And when I'm talking about translating medical terminology there, what I mean is taking the synonymous terms, medical jargon, and any abbreviations, and you assigning a standardized and uniform alphanumeric code from that information, so you get a consistent coded record. So an example would be, you've got three different ways of saying the same thing. You could call it a myocardial infarction, an MI, or a heart attack. It's all the same thing. They're just three different ways of saying it, and we've got one clinical code. It's I-21.9. classifies that disease. So that makes the data really comparable across all different trusts in the country, and even internationally. If there's another country using the same version of ICD-10, you can compare your data because you've got this standardized set of ICD-10 and OPCS-4 codes for your patients. So that's all entered, all that we've been through the coded record, the patient's record, sorry. We've verified all the codes, and we enter those into our PAS system, into whatever sort of software that's being used, whether it's an encoder or just directly into the PAS system. The data then gets processed, and that goes through the national HRG grouper. That then applies the tariff, which is the national tariff and any locally agreed contract flags that are in place as well at the specific trust. And that's how you get your overall cost of treating your patients. So if we look at that in a little bit more depth of how clinical coding drives clinical income. So the first thing to understand is this concept of an HRG. So an HRG is a health resource group. And what that means is you have groups of diagnoses or procedures that are quite broad, but they're clinically similar. So they're deemed to take up about a similar amount of resource, and they have a tariff assigned to them. They were used to underpin payment by results, which was the previous payment framework for the NHS. That model has now gone away. It was suspended at the start of the COVID pandemic, and it's not been reinstated. And now we're on to a different funding model, which I'll speak about in a little bit. So yeah, they're divided into admitted patient care HRGs, and then there's a handful of outpatient procedure HRGs as well. So to arrive at the tariffs that are assigned to each HRG, all the trusts around the country submit reference costs. That data is then analysed, and the tariffs are set based on an average. So it's not a perfect system, because you can end up with a cost that is significantly lower than what it actually costs you to deliver a service. So your service managers are likely to say, well, let's bump up our activity, and that the risk there is that there's an entire sort of section of your patient population that aren't receiving a service that is needed, or it could be the other way. It costs it costs too much to actually provide a service because the tariff is too low for you, and again, you end up deprecating a service that might be needed by your patient population. So it definitely isn't a perfect system. But even though we've moved away from payment by results and we're now on aligned payment and incentive, it's still the methodology that's used to underpin those contracting arrangements. And the way that works is there's two elements. I'm not sure if anyone knows all about the aligned payments and incentive scheme that's currently in place. But there's a fixed element and a variable element, and your fixed element is very much like a block contract, and then your variable element is basically dependent on whether you over or under deliver on your elective planned activity. So you will receive a percentage greater or lesser than the overall underperformance based on the tariff that's assigned to that activity. It's quite a clever structure, the HRG structure. So you've not just got a set of HRGs, they're then subdivided into a hierarchy, and what that's for is to recognise that even though two patients may fall into the same group based on whatever's wrong with them or the care that they've received, they actually might be very different in terms of the comorbidities, so that the complexity of that patient. So most of the HRGs are hierarchical to recognise that there are differences in your patient cohort, and there's an escalated income for the more complex patient within the same groups. So how does what's written in the case record influence this? It really, really matters what the doctors and the nurses write in the case notes, because the coders can only act on what is documented. So we can only extract the information that has been clinically documented, and we can only work within the confines of how it's documented. So it very much is a case of say what you mean, because we're not allowed to assume anything within clinical coding because we're not clinically trained. So here's Rex. He's our analogy of the HRG grouper. It's a really, really complex computer algorithm, but it's too complex for me. So we have a sausage machine. It works in a similar way. So the various bits of demographic information going, so admission method and length of stay, plus the ICD-10 primary diagnosis code, any comorbidities, and then any OPCS 4 procedure codes, they go in. The grouping logic does its magic and it spits out your HRG at the end. Your HRG has a tariff, and that's your safe and sustainable clinical services delivered. Bear in mind that safe and sustainable section, because I'm going to come back to that in a little bit. And you might have seen as well that one of the first things that goes into the grouper is length of stay. So there is something within the HRG logic called trim points. So each HRG for admitted patient care has an expected length of stay that's assigned to it. So how long you would anticipate a patient to stay in hospital if that was the HRG group that they fell into. To acknowledge that that isn't always the case, and you can't always assign a number to these things. If a patient stays over that number of days, they've reached that trim point, there is then an excess bed day payment. So that's additional income for every day that patient remains in hospital, basically to cover the costs of them being in a bed. It's important to note, because deliberately that sum is less than the cost of actually managing a bed, and that's to discourage any trusts from just keeping the patients in a bed longer than they need to be, to attract that excess bed day payment. It's also an easy trap to fall into, because you can see that as a quick win, but actually the real term gain is if you get that patient discharged, you get another patient into that bed that will attract a higher HRG. Then the HRG will be higher than the excess bed day payment. And this is just a quick overview of the total number of HRGs is 2,800, and of that, nearly 1,800 are tiered. So it is the vast majority that have that structured approach where they account for different levels of complexity within patients. And again, just an overview of how that works. So you start on your base HRG, which is the minimum income you can get for that. That's based solely on your primary diagnosis. But then as soon as you start adding comorbidities, you drive that complexity up, and that's where you start to trigger your paired and your tiered HRGs for escalated income. And we've got a few worked examples of that in a few slides to show you the impact of it. So comorbidities are really an essential piece of the puzzle when we're clinical coding. They play a really big part in not just income, in a lot of other factors as well for what the data is used for, but income is one of the easiest ways to see the difference. So the medical dictionary describes a comorbidity as a concomitant but unrelated pathological disease process. Clinical coding definition is quite similar. It's basically anything that coexists in conjunction with another disease. So whether it's an acute infection that happens whilst they're in hospital, we'd count that as a comorbidity, or whether it's a chronic condition that the patient's had for a number of years, we'd code that as a comorbidity. And both of those things would have a weighting assigned to them that could drive the complexity up in terms of HRGs. So when we are coding a patient's record, we can use the whole of the documentation that pertains to the current spell. So the spell is the date of admission to the date of discharge. We can use the whole lot of that. We can't use anything outside of those dates, but everything within those dates we can use to extract information, as long as it's the information is reported by the responsible consultant. So again, that means we can extract the information that they document. We can't make any assumptions about things that they hint at. So it is really important that the clinicians document clearly to make sure that we get exactly the right level of income. So here's the worked example. So if the patient comes in and they've got a primary diagnosis of cystitis, they don't have any other comorbidities documented, so nothing else is assigned, and this is the HRG that they fall into. So this is a CC score, so that's your complexity and complication score, and it's 0 to 2, so that's the lowest it can be in this HRG bracket. That's got a base tariff of 924, and an MFF is a market forces factor uplift. So every trust in the country has a percentage uplift. It's basically to do with the geographical location. So my trust in Manchester, it's just around 5%. So there's an additional £50 for that patient, giving us a total price of 974. But then if we revalidate the documentation and we notice that on the blood results, the patient was anemic, and it was documented that they had anemia, and they scored highly on the frailty score. Again, we can code that. So we stay in the same HRG bracket, but the Q has now become a P, and that's pushed the CC score up to 3 to 5. So we've got almost £1,000 more for those two comorbidities being recorded. Validate it again. The patient didn't just have one set of deranged blood results, they were also hypokalemic. And then in the nursing documentation, we found that the patient was a bit off their legs trying to get mobilised to the bathroom. So we've got some difficulty in walking. So now we're into N on this HRG, which has driven the CC score up to 6 to 8. The overall tariff there has now gone up to £3,000. What's really important to sort of take away from this example is that this isn't just additional income. We're not trying to fudge the books to add in extra codes to drive the cost up. This is unrealised income. So this patient had these conditions. it always costs £3,000 to treat them. But if these conditions aren't documented, the clinical coders can't assign those codes. So you will get this lower figure. So you're not covering the cost to treat your patients effectively. So when earlier I spoke about HRGs driving safe and sustainable clinical services, it's only true as far as the recording and the capture of all that relevant information is spot on both the clinician's parts in documenting it accurately in the case notes and the coder's parts in extracting that information and assigning the correct codes for it. Here's another example to do with procedures. We've spoken a lot about diagnoses so far, but a lot of the HRGs are actually procedure driven. So as soon as you start adding procedures into that patient state, it tends to shift things into a more procedure driven HRG. So again, we've got the same sort of thing. You've got a base HRG of 8,000, and then if that escalates to the next bracket, so this bracket is 0 to 7 CC score, the next one is 8+. So there's an 8,000 to 10,000 pound sort of gap in the base HRG to the tiered one. But if you notice here, the secondary procedure code, there's a difference of 1 in the 4th character selection. That has had a huge impact on the HRG that's achieved. So it shifts the HRG totally from 20 to from 21 to 20 based on that approach code, and that changes your whole income in the order of £2,000 to £3,000. What this highlights is the importance of really accurate documentation. So just describing a procedure as a TAVI will likely get you this because it's the most common approach route for a TAVI. However, if the clinician always does TAVIs and always uses this approach, but they decided they don't need to document it because it's the way they always do it, it won't get recorded in that way. Likewise, it's 1/4 character out. That's a really easy typing error for a clinical coder. So the coders do have to be on their best game all the time to make sure that the right information is being input into the clinical systems to make sure the right HRGs are captured. So is it reasonable then that if a patient has a long-term or permanent comorbidity, that should show a consistent pattern of coding in their record? We'd like to think so, but the reality is that about 10% of spells are missing comorbidities you'd expect to be persistent, and of those they have an impact on income as well. It comes down to how coders and clinicians interact, and it's not just coders, it's all the additional services from procurement to finance to costing and how we engage with the clinicians. The research showed that coders were very good at extracting the information, and the problem lay in the documentation not being adequate. It's important to remember though that the clinicians are responsible for looking after the patients, and it's not a case of just pointing blame and saying, well, the clinicians need to do a better job. It's about engaging effectively with the clinicians to explain to them exactly what is needed by coding and why it's needed in that specific way, so that you can have a positive conversation and really get that positive change in documentation recording. And part of that comes about explaining to clinicians what can and can't be used by coders and what the expectations are of coders. So there's certain terms that coders can use when they're assigning the codes from the information they extract. So if a condition is described with or modified by any of these terms, we can take that as that's the diagnosis, that's the code we can assign. However, if they're given these more vague modifiers, then we can't take that as a clinically definite statement. So we couldn't assign the code. What we find is a lot of clinicians use impression, and that's part of their medical training, and a lot of them use suspected. I would always advocate use treated as if it's suspected, because if it's suspected and you're going to prescribe something anyway, then you have effectively treated as. So that can be the difference. And conversations I've had with clinicians is that they know there are these rules, but they forget which terms they can and can't use. So it's about making this sort of information as readily available to clinicians and almost spamming them with it, making sure that they've got it over and over again until it becomes a habit, what they should and shouldn't write and how they should and shouldn't write, to make sure that the cost, that the income received is appropriate and is reflective of the care that they've delivered. Likewise, it's about the expectations of on coders. So, like I said, that we're not clinically trained, so we can't use any of these diagnostic test results. Most coders would probably know, well, most people would probably know that a BMI of 27 suggests that the patient's got obesity, but a coder wouldn't know that a raised troponin level is angina or a heart attack. That's a clinical decision. So just documenting in these shorthand test result ways, it's really difficult for us to then assign the right codes. So an example here is this patient was admitted, she fell over the dog and broke her knee around the site that she'd had a knee replacement. While she was in hospital, she developed a urinary tract infection. But here at the bottom, you can see she's got a BMI of 34. She's got some derangement of her EGFR levels. She's got type 2 diabetes and osteoarthritis in her hips and knees. So this is the information from what we have documented here. This is what we can extract. We've got the fracture caused by the fall. We've got the fact that she had an infection with a bug as the cause. She's got type 2 diabetes and she's got osteoarthritis. She had a CT scan done. That gets us this HRG, which gets us this amount of money. But as we saw in the previous slide, there are some test results. So if we look at the same information again, the BMI is now being described as obesity and the EGFR is now being described as CKD3. These are both things that we can and should code, and the income's gone up by over £1,000. Again, this just highlights that it's not additional income, it's unrealised. This information was always documented. It's just the way in which it was documented wasn't usable by coders to be able to assign these definitive diagnoses and get that right level of income. The next one is obviously legibility. So we all joke about how poor doctors' handwriting is. And the simple fact is that a lot of trusts still use paper case notes, so we are dependent on reading the handwriting of clinicians. And when we come across things like this, it's incomprehensible. We can't use it. We would maybe do the best we can with what our best guess is. Worst case scenario, we'd have to send it back and say we can't code this until this documentation is brought up to scratch. That can have a knock-on effect, delaying the completion of coding, and it might miss its contractual deadline. So neither of those scenarios are particularly good. Compare that to an op note that's being typed into different sections, comes with a labeled diagram. That's brilliant for a code. This is a coder's dream. They've got all the information they need in a format that's easy to read, side by side with a diagram that points to exactly the parts of the anatomy, so that they can see exactly what was done where, and they can use this to then assign the correct codes. So teamwork makes the dream work. Again, it's really easy to say, well, a lot of the issues here lie with the clinicians, and the clinicians need to do more. But their primary job is looking after patients. It's not worrying about what coders are doing. It's up to the admin departments like coding and finance and costing to engage, to demonstrate things like this and the importance of it, to show the impacts of changes to documentation and how that affects income, and create that positive relationship with them to drive these changes. That is the end of my presentation. Are there any questions? Feel free to shout out. It's just a question dropped into the chat from Hannah. How do clinical coders handle procedures carried out on a patient who is part of a research study? Could be a research specific procedure or could be part of their expected pathway. So research procedures are quite interesting, and it actually depends on what the research is. So by and large, we would code it in exactly the same way. as we would any other patient. So if they're having that procedure in an admitted patient care setting, we would just assign the codes in the same way. It would be up to then the grouping logic within the contracting team to sort out any differences to the funding based on the fact that the patient's in a research group. The coding wouldn't be impacted by that. We'd code in the same way. There's certain parts of chemotherapy though, where if it's a trial, we wouldn't code it, largely because that would be recorded on sort of like a national database, and it'd be funded directly from the trial of that. Does that help, Anna? Happy with that. Any other questions? Take that as a no. There's my details on that slide. By all means, feel free to get in touch if you want to know any more, or if you do have any questions, just drop me an email. I'll be happy to answer anything you've got. But yeah, that's everything from me. So I'll hand back over to Becky. Thank you very much.